All right, good afternoon, and thank you again to the organizers. I look forward to telling you a little bit about yet another area of research here. And I'm going to ask what happened to the clicker. Is this, got it. Okay, it looks like a remote. Yeah, it doesn't look like the normal ones I see. So I'm going to talk to you a little bit about a program we've been doing since about 2012 at the NIH called the Healthcare Systems Research Collaboratory. We have in the room one of the PIs of the coordinating center, Adrian Hernandez, who we've heard from earlier, and he's on the discussion panel a little bit later. And the mission of this group really is to strengthen the national capacity to implement what we called cost-effective, large-scale research studies that actually engage healthcare delivery systems and those organizations as part of one of our research partners. Really trying to leverage that data that's already passively collected as part of the electronic healthcare system, and how can you use that, and when does it make sense to use that? It doesn't work for all types of trials, but when can we actually partner with healthcare systems and answer questions that they want answered and that will actually improve healthcare in the long run? And so we've used the term embedded pragmatic trials because they're embedded into the healthcare system. As how we talk about them. And so we don't necessarily talk about these as virtual because people still go in to see their medical professionals and get routine usual care as it happens in their healthcare systems. And we're just leveraging the data around them. We might randomize clinics to do different types of interventions, or we might randomize different providers to have different types of care available to their patients, or different electronic health record tools and prompts and other things like that. And when we started, we thought this was going to be very easy. We thought we would just be able to push a button at the end and we'd get all the data and it would just be very, very easy. We knew there might be some challenges, but it's not all that easy. And I'm going to hopefully give you some lessons about when this type of model really works and when I think it may not be the best model for doing studies. And a lot of what you're talking about here with this, whether you call it a virtual design or a direct-to-patient type of design or these hybrid designs, might really help. You can use some of the electronic health record data, but not necessarily rely on it completely. So my goal is to talk to you, give you a little bit of background and a little bit more information about the Collaboratory that we're doing here at the NIH. Talk to you about what we meant by leveraging the electronic health record and some of the challenges and some of the solutions that we've come up to deal with those challenges. And then share with you some of the lessons learned, some of the things we expected to be difficult, and some of the things that we didn't expect that have been difficult, and give you some ideas of sort of where we might be able to go with this in the future. So the Healthcare System Research Collaboratory we're almost done with the first 9 trials. These are the sites that were done across the country. The one that's not listed here on sites is the study that was done with Hospital Corporation of America, which randomized 50 hospitals in a whole variety of different sites. We didn't put all of those locations up here. But you can see we do have a pretty diverse range of states that were involved in the different studies. And we do have 6 new trials that were funded over the spring and summer of 2018 that will be added to this map. And we've just announced a notice of intent to publish to fund another set of trials looking at how to improve pain management with evidence-based guidelines in healthcare systems as part of the HEAL initiative that NIH is doing that will be funded in September of 2019. So we're continuing to do this because we really do like this model. And so we have sort of the coordinating center that's really, it's not a data coordinating center, they're really a resource coordinating center. And so they help each of the demonstration projects or each of the individual trials that we funded through a series of working groups, and then they take lessons learned and put those onto their knowledge repository and into, hopefully then those get implemented into actual learning health systems. And so resources that are available to you, everything that we put out there is on the website, rethinkingclinicaltrials.org. They've actually developed a really nice series of textbook chapters about how do you do trials when you try to embed them within healthcare systems. So there's different sections on how do you design these types of studies, how do you conduct them, how do you then disseminate them. And also here you can find out more specifically about training resources of how do you do these kinds of studies. And then each of the individual work groups has its own page. And here I'm showing you an example from the electronic health record page where we know there are many other resources that are out there, and our goal is not to recreate them, but to make them easily accessible and findable. So one of the topics that we had to deal with was translating from ICD-9 to ICD-10, happened in the middle of most of these trials. So how do you map how you identify patients in months 1 through 18 to how you're now going to map to the patients that are enrolled month 19 through 36? And so they did actual mapping where they were able to pull data and see if we use the algorithm from the ICD-10 codes, can we get the same participants that we had with the ICD-9 codes? And we were able to do some of that work, and the work groups were able to sort of help facilitate that. There's many, many resources on here, so I encourage you to take a look. There's grand rounds that are done on a weekly basis, and they're all archived on here. And so there's one here that's thoughts from the phenotypes and data standards and data quality core. You can always go, if you have a particular topic that you're interested in, that you can find out more information here. And so that's one of the things I wanted to make sure that you were aware of and that's available. There's publications and white papers and lots of things that come out of these groups, so that our goal is so that it's easier for everybody else that's not necessarily part of the Collaboratory to do this work in the future. That's really one of our big goals. So leveraging the healthcare system and the electronic health record, I think we've already heard this a little bit, is there's all of this data that's already there. Let's use it, right? There's no cost. It's already collected. It's there. That's the potential that's there, and I'll talk to you about some of the challenges, but it is true. We are capturing all of this data on all of our patients as they're being seen. They're getting lab tests, they're getting imaging, they're getting all of this stuff. Why do we have to recreate it all when we go to start them into a research study? Why can't we use what's already been done? And so one of the things to think about if you're thinking whether this type of trial might work for you is what data really is consistently there. And I can tell you that the data that's needed for billing is there. And the data that is needed to qualify for certain codes and things like that will consistently be in the record. And procedure codes and things like that, so that you can bill for them, are going to be accurately reported in the system. And so if those types of outcomes would be useful for you, then this might be a really good type of study design. And so many of our studies are looking at things, for example, we have a suicide prevention trial that's capturing when people are admitted for a suicide attempt. So it's the visit itself that is the outcome measure that they're looking at. And so that's going to be captured by their systems. So I'm not going to lie, there are a lot of challenges when working with electronic health record. One that we ran into is the fact that there is going to be more missing data when you're looking at electronic health records. One of our studies is looking at sort of how do you coordinate care for pain patients, and particularly complex pain patients who might be on both high-dose opioid medication as well as benzodiazepines, and how do you coordinate their care so that they potentially need to see less specialists in the system is kind of what they're hoping for. And all of the medical systems that they were working with are supposed to have the brief pain inventory as part of it. Well, when they started in their planning phase looking at how frequently that was actually in the system, in some sites it was like maybe 60 or 70%, and other sites it was 20 or 30%, and in other sites it may have been even less. And so that field may exist, but it may not be utilized. And so it's important to look at that as you're thinking through these things. And I'm going to give you a solution on the next slide of how they've actually addressed that problem. The other issue, I mentioned the suicide prevention trial. Well, what if they get care somewhere else that's not actually part of your healthcare system that you're working with? So this study was done with group health and with some of the Kaiser systems and Mayo systems. But what if they went to urgent care? Or what if they were brought to a hospital that wasn't part of that system? How can you capture that? Typically, the healthcare system may get billed for it, so you may be able to find it in the billing records, but not in the electronic health records because they didn't actually appear there. So you've got to think through what are the other sources and where might you be able to get information. The other thing that I would say is most patient-reported outcomes are not consistently collected on a routine basis. There are some exceptions to that they are done very consistently, but more often than not, I gave you the example of the brief pain inventory, they're not in the system. Adverse event reporting is typically not captured very well in the system, so it's not a common question that's asked. And the biggest challenge I think we face is that in a clinical trial, people come in for specified visits. They come in, in a depression trial at 2 weeks and 4 weeks and 6 weeks and 8 weeks. And I think we heard earlier that, you were lucky if you saw the Parkinson's patients 4 times a year. Well, for other patients, it may be once a year. And is that frequent enough data collection for you for the trials that you're doing? So here are some of the solutions that we've come up again, that are PIs. I should give full credit to the PIs in our system. Linda Barr is the one who's doing the pain study out in the Seattle area. And what they've done is they've augmented the data capture of the brief pain inventory by initially doing an email to people where they can click a link and be able to fill it in online. If they don't respond to that, then they get an automated phone call where they can press 1 if the score is this or press 2 for that. Again, it doesn't require any staff time to do that, so it's low cost. And then if they don't respond to that, then an in-person call actually happens to capture that data. And that's gotten her data up much higher in terms of data collection. Certainly these types of things can be used. We've seen a lot of examples already for how to do this via mobile apps or other types of things. The other thing that Dr. DeBar did is she used some more creative analytic methods. So rather than saying she needed to have data at 8 weeks at that particular time point on everyone, she used trend analysis over time so that people had variable amounts of follow-up based on when they actually showed up for their visits. And so she was able to look at regression over time rather than trying to specify it for a specific time point. And so that's one of the techniques that they found really useful. And you have to work with your biostatisticians to be a little bit creative. And I would say the biggest thing that all of our studies have a planning year where they've got to actually show us that they can get the data out of the system and how much missingness is there before they're ready to launch the trial so that they really know what they're up against and whether or not it's actually even feasible to do this. So towards the end here, I just want to talk to you a little bit about the expect the unexpected, some of the things that we knew were going to be problems. I talked to you about missing data. You have to expect staff turnover in healthcare systems. It's just a natural part of the system. Your champion who's been helping you and working with you is likely going to get promoted if they're really good, and they're going to be taken somewhere else if they're really, really good. With these studies, they are pragmatic, and so you have less really close adherence to the interventions. So that means that you have to power for a smaller effect size, so you need a much larger sample. The systems do evolve. I gave the example of the ICD-9 to the ICD-10. What we did not expect is how frequently staff do turnover in these systems. We expected some, but in some cases we had sites where there were 4, 5, 6 different people over the course of a 3-year study that were having to do things. And so you have to have a plan for retraining. We had new electronic health records that were launched in the middle. Surprise, we're changing. So how do you deal with that? How do you deal with those kinds of changes? And how do you confirm that you can get the same data from one system to the next? The other thing that we keep hearing is that change is constant in these healthcare systems and that nothing is static. And for Dr. DeBar, who's working in the area of pain, prescribing things changed. In the state, there were new laws that were passed that they had to reduce prescribing patterns. We've been doing studies within VA healthcare systems where they've initiated things and the patients that you used to be looking for no longer exist because they're not being seen in the VA anymore. They can't prescribe those levels of opioids anymore. And so we had some people that were doing stepped wedge designs, and it really messed up their study design because the control time period was not the same as we progressed through time. And the biggest lesson we learned is that we thought we would just hit that button at the end and the data would be there, and it's not. And what we've learned is that the data is there, but you also need to clean it to make sure that it's really what you expect it to be. It's helpful to get data periodically in data dumps to make sure that, oh, we've changed a code and now half of your people just disappeared from your data set. If you do that in real time, the IT people haven't left that made that change. And so doing that periodically is really important. But it's still the priority you've got to remember for the healthcare system is billing. And so that's the top priority for where the data goes first. And as they're making all of these changes, your research as a priority may be very low. And so how do you work with them in making sure that they want the data too and it becomes a priority for them? So in closing, I've just got a couple of slides here to sort of say, I think what we've heard before is keep it simple is the big thing for a lot of these studies. We find investigators, like you said, keep wanting to add this and add that and make something else. And for these pragmatic trials, we try to keep it very simple because if you're going to partner with the healthcare system, you have to make it easy for the clinicians and for the patients that are delivering the healthcare process. You can't add all of those steps. The 7-minute visit, or is it the 5-minute visit or the 3-minute visit now, they're not going to be able to capture all of that additional data that you may want to have. So that's a very big challenge. I will say that the cost of these trials can be much less. The total cost that we've allowed for the trials that we've been doing is $4.5 million in direct costs over the 5-year period of the studies. A few have needed a little bit of additional support, but the sample sizes have ranged from 200 to almost 200,000 participants in the trials. So the cost per patient does vary depending on how intensive the intervention is, but they can be quite inexpensive per patient. And so then my last slide here is really just sort of when is this the right choice for the study design? It's when your outcome of interest is actually captured by the electronic health record, when you have a partner of a healthcare system that is actually as interested in the outcome as you are as an investigator. Linda Barr's study that I gave you the example of, it was her healthcare system that came to her and said, we have patients that are touching our services 30 times a month. What can we do for these patients? Because clearly they're not getting what they need. So how do we better deliver care to them? And given that we're talking about this sort of around drugs and devices and things like that, I think it might be hard for novel initial phase 3 types of trials, but for new indications, I think it's a better option. And if you don't have to have study visits or you can minimize them, I think that this is a model that might work. So I will end there.